Okay, well, good morning or good afternoon, wherever you're located. Thank you very much for registering and attending this little webinar. My name is Mary Coughlin, and I'm the president and founder of Caring Essentials Collaborative based in Boston, Massachusetts. My background is a neonatal nurse practitioner. I've got over 30 years of nursing experience, and right now I'm all focused on my consulting, education, coaching clinicians to transform the experience of care for the infants and families that they serve in the newborn ICU through the adoption of this concept of trauma-informed age-appropriate care, which you'll get a little bit of an introduction to today. So at the very end, I'll give you some extra information. I think we can take some questions in the chat box and stuff, and we can attend to that at the end of the session. So if everyone's ready, I'm going to go ahead and start the slides. So touch a life, impact a lifetime, trauma-informed care in the newborn ICU. Oops, let's see. Okay. Just to kind of kick this whole talk off, I think it's important for us to understand the capabilities, the affective capabilities of these individuals that we serve in the NICU. Early emotional experiences actually do become embedded in the architecture of these developing humans, and it frames how they walk through the world. It frames how they understand whether or not the world is a safe place or a really scary place. Your learning objectives for today: I hope at the end of this session you'll be able to describe the biological mechanisms associated with toxic stress, identify the #1 traumatic experience of the hospitalized infant, and truth be told, of any infant, and be able to list 3 evidence-based strategies to mitigate the trauma experience of the hospitalized infant. We're going to kick this off with an introduction about toxic stress from the National Scientific Council on the Developing Child.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
And I think in general, we all understand that children need to have a nurturing environment, but I think sometimes when we're in the NICU, we overlook or we forget that these individuals do have this whole human developmental side that can often go unattended to because we're so focused on their medical or surgical condition. And I completely get that. I'm an adrenaline junkie, as I know most of you guys are, but we really now need to respect and honor those human dimensions. As the evidence is now pouring in, it really is changing their developmental trajectory at a genomic level. So here we see this little person and just the quote from the video about the sustained activation of the stress response, impairing learning, memory, and the ability to regulate your emotions. I want you to just kind of take a look at this little person and just reflect on, what could be stressing him out. Does he look stressed? Or does he look pretty chill? And I'm sure many of you have already noticed, well, the light is really bright. His hand is up over his face. His face looks a little bit stunned, if you will. His nares are flaring. He's got a tourniquet on his left forearm here. I don't know if you see that in the foreground of the video. And these are things, you know, that sometimes we can take for granted. And when I talk like this, I'm really talking from my perspective, my background. I'm not trying to say that everybody wasn't as not so great at this as I wasn't so great when I was a younger NICU nurse. But again, I think the way we acculture our newbies into the environment really then perpetuates some of these behaviors that we're now discovering are less than optimal to meet the human needs of these individuals. Take a look at the amount of tape that's on this little person's face. I mean, I totally get we need to secure these lines and tubes, but we really don't need to have that excessive amount of tape. So it's really in the little things that we really have a great opportunity to make things a little bit better for these people. We know that toxic stress is bad. This is a really cool MRI making a comparison of a 3-year-old's brain. The brain on the left has had a normal, healthy childhood, and the brain on the right is the brain of a 3-year-old individual who was nurtured for the first 3 years in an orphanage environment where they suffered profound relational deprivation and sensory deprivation. And this, to me, is a pretty graphic representation of the changes that occur at the neuronal level. Toxic stress is that frequent extended activation of the stress response, which, again, go back to the video, you saw these synapses actually melting and disconnecting. Neurons that fire together wire together. And when the brain is always pumped on, is in a high state of alertness, and the stress response is activated, then you're going to see a redirection of the neuronal architecture to that fight or flight response, and all of those other networks are not going to get the proper stimulation, and you're going to actually see things like this. Now, I just want to say, you know, before we move on in the slide deck, not all stress is bad. You know, there is some positive stress. I know this sounds funny, but anytime I speak, even here on a webinar, I get a little bit nervous. Not a bad nervous. I get a little bit of nervousness that is around kind of elevating my sense of focus. My heart rate's up a little bit, not in a bad way. It's just to give me that energy that I need to move through and share this information in an engaging way. Nothing bad's going to happen to me from having that positive stress. And in fact, I adapt, and hopefully I present this material in an exciting, engaging way. That's positive stress. Tolerable stress, those are the stressful situations where, for example, maybe you have to go in and have some kind of a medical procedure or something, but somebody goes with you to support you through that difficult situation. You know, if it was left unsupported, the event was left unsupported by a caring adult, that would then flip that tolerable stressful situation into a toxic stress situation. So toxic stress is that activation of the stress response without the buffering presence of a caring adult. And ideally, the most important caring adult is the child's parents. There was a really cool study, a paper published in 2011 in Annals of Neurology, where this group actually, could somebody mute themselves? Where somebody the group
he was looking aside from me.
Few clinicians sat down and looked at all of the potentially stressful things that could happen to a patient in the newborn ICU. And it was everything, soup to nuts, from intubation and chest tube insertion to being cared for on a radiant warmer, to having mouth care, to having leads put on your chest. I mean, everything that you can imagine. And then they weighted these different things, saying that like a chest tube insertion is probably way more stressful than having leads on your chest, but again, still stressful. So they weighted them all, and then they validated the tool amongst themselves, because unfortunately the babies aren't able to quantify the results. And so once they refined the tool, they then went and scored a group of babies over the first 2 weeks of hospitalization in a newborn ICU and scanned their brains. And so what this picture shows here is that top row of brain, that's the control group. These guys just had a normal, regular first 2 weeks of life, not even in a NICU, it was just the control group of healthy people. And you can see this, kind of symmetric balance of these diffusion weighted spectral components. I'm not an MRI person, so I can't get too technical with this, but you can see this symmetry here. In row A. In row B, these are the people that had moderate stress. So on the scores, it wasn't in the far extreme, but they were definitely above a 0 stress score. And you can already start to see that there's this asymmetry now in these diffusion weighted images, suggesting that something is changing at the anatomical level. And then on the row C, these were the babies that had the super high stress scores. And you can see that there's almost no communication. Bilateral across the hemispheres. And so what these folks deduced is that high stress exposure is indeed associated with anatomic and functional changes in the brain, and that these stressful exposures may play a key role in the neurodevelopmental outcomes of the people that were taken care of in the newborn ICU. Now, so this is cool. This is 2011 information. But what's really fascinating is we actually had, as a body of scientists, we had an inkling that maybe bad stuff that happens to you as a child plays out in a bad way in your health across your life continuum. And evidence of this was supported by this adverse childhood experience study, or what they called the ACE study. The ACE study was done back in the mid-90s out in California through Kaiser Permanente. And the story of it was really interesting. There was an obesity clinic. I know this sounds weird, I'm a NICU person, but it'll all make sense shortly. So there was an obesity clinic, and they were really trying to come up with some really great ways to help people address their obesity. And so they had this really successful case study, a young woman aged 28, she weighed over 400 pounds, and in about 56 weeks or something, she went from over 400 pounds to about 132 or something amazing. And the doctors were patting themselves on the back. This is the greatest thing. And about 3 weeks or 4 weeks later, the woman started quickly gaining weight. And she had told the physicians that there was an older man that had sexually propositioned her in the office, and she just started to really unravel. And, as they had continued to interview her, they discovered that she actually was a survivor of sexual abuse as a young child from a grandfather figure in her family. So they thought, gee whiz, let's see if this is a one-off. And they interviewed the rest of their the cohort of obese people that they served, and I think it was more than 55% of them had a history of sexual abuse. So they thought, okay, this is really interesting. We need to dig deeper. Is this just something unique among this particular patient population, or is it more pervasive? And so what they did is they sent a survey out to over 17,000 people. These were middle-class white people, and they asked them about adverse childhood experiences, to include various kinds of abuses, neglect, emotional and physical, and levels of household dysfunction. It was fairly comprehensive, and what they got back in the results was pretty significant, in the fact that the majority of people experienced at least one ACE, and for those that experienced at least one, there was a subsequent ACE. So it wasn't like it was just this isolated event. It seemed fairly epidemic. And then they started comparing the reports of these ACEs to the health and welfare of the population that they were serving. And I'm just going to read some numbers here that was pretty significant, though. 87% of the respondents of the 17,000 people reported at least one ACE. And that in this population, if you reported 4 or more ACEs, the likelihood of you developing chronic pulmonary disease increased by 390%. You had a 240% increase in your risk for depression, a 460% increase in your risk for suicide, a 5,000% increase in becoming an IV drug abuser if you had 4 or more ACEs. And so, you know, the study's been replicated, oh, I'm so sorry, a number of times, and in a variety of different demographic groups. And really it's come out that it's not a racial thing, it's not an ethnic thing, it's something that happens at a biological level to ourselves when we have these adverse childhood experiences that really represent this toxic stress. Because when a child has an adverse experience, their HPA axis kicks into overdrive. They're pumping out cortisol and catecholamines and all these other kinds of things to survive. And that is actually degrading and undermining their ongoing neurodevelopment. So you can see here from conception to death on this graph, in the setting of the adverse childhood experiences, what transpires from that is a disrupted neurodevelopment that negatively impacts the social, emotional, and cognitive impairment. Again, think back of that little video on the toxic stress. This cohort then tends to adopt health risk behaviors, and I'll talk a little bit about the genomic components of this, and all of this sets them up for increased risk of some serious diseases, disability, and social problems, and an early death. And what's really interesting is through these epigenetic mechanisms that I will mention in a minute, there is an intergenerational or transgenerational transmission of then vulnerabilities or methylations of different genes that increases the vulnerability of the next population, even in the absence of adverse childhood experiences. So it's certainly a public health concern, and that's been recognized by the SAMHSA organization, which I'll also mention. But, you know, so take that information within the context of the neonatal patient population. And what we know is that 50 to 70% of infants born premature develop behavioral problems, including internalizing or externalizing problems. Internalizing problems are precursors to things like depression. Externalizing problems are like anxiety, acting out, oppositional defiance disorders, and those types of things. And then they're also, we know this, they're at an increased risk for attention deficit hyperactivity disorder, which now researchers are looking at PICU and NICU survivors. Are these ADHD behaviors really a manifestation of post-traumatic stress disorder, or PTSD? So we're really getting involved in understanding the experience that these individuals are having and how that experience is actually changing their biology. Infants that are hospitalized for a term cohort, this is Marino et al. Infants that were hospitalized for congenital heart disease had an increased risk for neurodevelopmental compromise if they had a longer post-op stay. And again, you can say, well, gee whiz, Mary, they were probably sicker. Absolutely. But they can't pinpoint what, is it related to severity of illness? No, it's not. It's just that they're in the hospital for a longer time. And again, think about the hospitals. Hospitals aren't designed to be these nurturing, loving places like mom and dad's home, hopefully, or some other type of warm, fuzzy place. We're very function oriented and that sort of thing. And we tend to fall off on focusing in on those human needs and those quality caring needs. Blasco and Francella identified an increased risk of violent suicide attempts in individuals born prematurely, and again, that kind of spins off from the ACE study. We know these individuals are at higher risk for cardiovascular disease, to include hypertension and myocardial infarction, and also an increased risk of metabolic syndrome and obesity in adulthood in NICU survivors, which is a really interesting phenomenon, and I'm sure a lot of the therapists would be intrigued in understanding more about this, as the researchers are uncovering more and more, so that we can get a better understanding of these mechanisms. Compared with term births, individuals that are born premature are at higher risk for schizophrenia, depressive disorders, and bipolar disorders. And the more premature you are, the higher your risk is. And these conditions, these are quality of life busters. I mean, these are horrific diagnoses that basically lead to lifelong impairment and hospitalization, and just, it's just not a nice life. For us, it's really, really, really important for us to understand that the people that we serve, the babies that we serve in the newborn ICU, they interpret the world from the bottom up. And when I say the bottom up, I mean the bottom of their brain up. from how the world makes them feel and how those feelings affect their brainstem, right? So think about, when through the process of neuroception, I'm not sure if you're familiar with this, but neuroception is that kind of that sixth sense that we have, like somebody's sneaking up on me, or you ever just get chills down your spine when you're, in a certain setting and you're not really sure why. Neuroception is your body's kind of danger detector, if you will, just to warn you that something may be amiss in your environment. And this is the process that then activates your stress response so that you're alert and that you're ready to respond either by fighting or fleeing. The same biology is fully operative in the people that we serve, regardless of their GA, all right? I mean, the integrity of your brainstem functionality and your affective capabilities are fully formed well before the third trimester. So these feelings, and feelings are really basically the conscious awareness that you're having an emotion. And the emotion is basically a biochemical activity that's happening within inside your body that is the result of some detection of either something really good or something not so really good. So that's how babies make meaning out of the world. So think about what the bottom-up experience is when you have a life-threatening illness and you've got tubes and lines and all this other kind of stuff on you. Nothing is familiar. You don't smell your mom. You don't hear your mom. You don't, all of that stuff that was very comforting to you is completely gone, and now you're in this situation. And I get it. We need to save their lives, absolutely, but it can't be mutually exclusive to meeting their basic core biological needs as a human being in feeling safe, in feeling secure, and consequently then turning down that HPA activity and letting them feel at least a tolerable stressful experience, all right? Because I mean, there's no way we can make it perfect, but I think there are ways we can definitely make it better. In understanding what are these critical and sensitive periods of development, and that once these periods have passed, that's it, the door is closed, and those neural networks that were primed for stimulation and ready to expand and grow, in the absence of the proper input, they're just going to wither away and melt away like that video that I showed you. These sensitive periods are mediated by these neurobiological mechanisms, and oxytocin is a big player in this. Oxytocin is the antithetical hormone to cortisol. Oxytocin is the one that tells you that, life is good and you're calm and you're connected with somebody else. And so you can see, in this graph from Feldman, that oxytocin is really dependent on this biobehavioral synchrony, this relationship-based activation that then supports these critical and sensitive neural pathways that need to develop in order to have a healthy socio-emotional and psychological developmental trajectory. Imprinting is really how this mechanism at least begins, shortly after birth, and how that infant is just waiting for the continuation of that maternal sensory experience. But when that maternal sensory experience doesn't happen, then everything changes. The biological footprint is altered, and the genetic footprint or expression of the genetic footprint is altered as well. Whoops. So I want you to really zoom in on this. This is a human brain development looking at the synaptic formation, the rate of synaptic formation by age. And I want you to especially focus in on this yellow line. You can see where it's marked birth, obviously these are intrauterine, potentially, depending on when you're born. And then this next barrier here, the months, all right? So by about 2.5 months, you are peaking at your rate of synaptic formation in relation to sensory pathways. So it's vision and hearing, but it's also olfaction, it's gustatory experiences, vestibular experiences. All of those sensory pathways are peaking in the synaptic formation, and basically, right, when neurons that fire together wire together. So, you're going to have synaptic formation when you have this proliferation of these neurons that are getting the right input and just growing and doing the thing that they need to do. In the absence of that, that peak is going to be blunted, and then understand how that's going to then play out and impact language skill acquisition, social development, and cognitive capabilities. So on our watch, it is all about those sensory pathways and protecting them and making sure that we are providing the proper stimulation. And the proper stimulation is not the smell of an alcohol prep or the smell of a CHG swab. The proper stimulation is the smell of their mom, the sound of their dad. These are the proper sensory stimuli, and smell of dad too. I'm not trying to be biased. I just default to mom, but you know, again, you can see how this all makes sense. In the setting of toxic stress, you're stressed because you're not getting these nurturing, rewarding sensory experiences, that the world is really scary. All of this sensory experiences that you had in utero have disappeared, and there's nothing taking its place. And so you've got this activated HPA axis, and it's influencing the way the brain is developing. And that's why you're getting these smaller brains in these individuals. And so what this concept of toxic stress does is it really rolls into this definition of what is trauma. The Substance Abuse and Mental Health Services Administration have this really cool guideline book that gives an excellent description of what is trauma. And again, in the old days, I would think trauma was a gunshot wound or a motor vehicle accident. But in fact, trauma results from an event or a series of events that is experienced by an individual. It's not me assessing your level of trauma. It's you interpreting as the individual how physically or emotionally harmful this situation is. And it includes life-threatening. So just by that definition alone, admission to the newborn ICU is a traumatic event because they are in a life-threatening situation. Even though we rocket saving their lives, their life is still threatened. And this real lived experience has lasting adverse effects on the individual's function and their mental, physical, social, and emotional well-being, and spiritual well-being as well. And so I introduced this concept it's not new. I just, co-opted it from mental health. But the idea of trauma-informed care is acknowledging that individual trauma indeed occurs. And in fact, we know from the ACE study that it goes well beyond medical trauma, that it is a lived experience, of these early life adversities. And so in understanding that trauma changes the biology of the individual, we as clinicians then have an opportunity, and I believe a responsibility, to then try and manage that trauma experience as best as we can to mitigate the lifelong effects of that. I hope everybody's good with what I'm sharing and I'm not talking too fast. These guys, Monterosi and Provenzi, they've done a lot of research around this concept of adverse experiences for the hospitalized patient population, the neonatal hospitalized patient population. And this one is from Joggin, I believe, where they actually graph out the NICU-related stressors and the NICU-related quality of care. One of their earlier papers actually demonstrated that the quality of care received in the NICU, specifically related to developmentally supportive care practices, actually had a positive impact on the infant's NNS scores, their neurobehavioral development at term equivalent. So, and then they just recently put out a paper looking at the quality of life of these individuals at 5 years of age, again, based on the quality of their developmental care. And the higher quality of developmental care, they had better quality of life outcomes at 5 years of age. So this is great for us, especially, for folks that are passionate about developmental care. The science is what's going to change behavior, but we have to be methodical about how we're going to operationalize this and introduce it to, into our units to get the right results. But this is awesome information. Again, I mentioned earlier about this epigenetic phenomenon, and there's been lots of work now done on how developmental exposures alter the genome, the gene expression, all right? So they alter the epigenome through these different mechanisms that are here in this middle blue box. These developmental exposures include transgenerational influences. Again, remember when I talked about the in the ACE study in the pyramid, that these stressful experiences can be passed down through the genes to the next generation. Clinical events, apropos for us in the NICU, nutrition, lifestyle, social stressors, again, all appropriate for the NICU, and even environmental chemicals. And we're familiar with a lot of this stuff, you know, the work that was done around the phthalates, and there was a study that was done looking at the air toxins, the airborne toxins in an incubator. And they're pretty significant. And I think the highest toxin was related to those alcohol hand sanitizers, that if you can just, when you use the alcohol sanitizer, if you can just let it dry outside the incubator before you introduce your hands, you can reduce the airborne toxins in that environment. These developmental exposures in changing the genome have resulted with these particular later life outcomes: compromised growth, neurobehavior, obesity, reproductive health, and even an increased risk in cancer. Actually, the ACE survivors had a twofold increase in their risk of cancer of all kinds. So again, you know, this toxic stress is pretty debilitating, and it's wonderful that we're now getting this information. Again, the Prevenzi guys and some other folks have looked at this SLC6A4 methylation, and that's it's a transporter gene for serotonin, and serotonin is that cool hormone that, you know, regulates your mood and, you know, makes you feel good and balanced with your emotions and that sort of thing. And what they found is that methylations are actually of this gene indicate adversity in humans. And so now folks are trying to figure out how can we work backwards to maybe minimize some of these methylations, you know, once we identify what these individuals that have this have been exposed to. These alterations in the gene are thought to affect circuitry across the amygdala and the cingulate. In the amygdala, that's, remember that little almond-shaped structure on either side in the subcortical area that's really kind of like fear central? That's that place where you have, it's a quick activator for the HPA axis and fear and terror. And cingulate is also around those core experiences that threaten your survival. And so, you know, understanding that level of biology and the anatomical functions that these organs represent, you can see how this toxic stress or this, you know, hypervigilance, and these individuals are just always watching out for the next shoe to fall because their experience has been so unpredictable and so threatening to them. Even though they may have been medically necessary, we just need to be mindful of how these actual things play out in the biology of the people that we're serving, because it does influence their developmental trajectory. And so this paper came out in JAMA, and these guys coined this term, which I think was pretty cool, epigenetics. If in fact we know that these early adverse childhood experiences are changing the genome, then aren't we ethically bound to do something about it, to do something about minimizing or mitigating this phenomenon? We can't eradicate it. I mean, these individuals are in a life-threatening situation, and we're doing everything we can to help them survive, but we can't do it just focused on the lines and the tubes and the machinery. We need to really honor the needs that they have as a vulnerable developing human being. Whoops. So I invite you to consider changing the clinical perspective from what's wrong with you to what happened to you. I mean, it changes that dynamic, because what's wrong with you kind of removes me from your experience, and it's you, it's not me. And it almost gives you the impression that, well, we can fix this, versus taking a look through the lived experience as what happened to you. Then you can really engage with more compassion and empathy about that lived experience and honor that shared humanity that we have with the patients and the families that we serve. I hope this is coming across good. when we think about, everybody talks about patient and family-centered care, and we've been talking about this for decades. When you compare the tenets of family-centered care and patient-centered care to trauma-informed care, there's a lot of overlap. So it's not like I'm not inviting you to swap out one paradigm for another. There's some mutuality here. And we should always, focus on the dignity, share information, minimize trauma experiences, really take a step back and say, we do these labs every Monday and Thursday in NICU B. Why? Because it's Monday or Thursday and it's NICU B. Is that really how we should be approaching the care that we're providing, particularly when those interventions are going to result in some kind of pain or distress for the patient? I know that there's a balance, but I really invite you to rethink how we operationalize our work. We do try and make it convenient for us because it can be overwhelming, but I think that there's some opportunities here to round things out and balance things a little bit more. We know that the developing brain is vulnerable, and I've just got it to 40 weeks. It's the first 5 years of life where it's kind of make or break, and then whatever strategies or experiences that individual has been exposed to. And when I say strategies, whatever coping mechanisms they've sorted out to deal with life is pretty much hardwired by age 5. And so if you want these individuals to always be afraid and that nobody's going to be kind and that the world is a scary place, okay, fine, great. Then, there's going to be some significant fallout on the other end. The susceptibility of the developing human being, we know this. These guys are easily affected and influenced by the care that they receive. Not only from a physical perspective, when we think about how, the friability of their skin or, the pressure points and all these other types of things, but socio-emotionally as well. And I think that this is a new place for us to go as NICU clinicians to think about the affective and the emotional capabilities of these individuals that we serve. There was some really cool information now looking at the the insula cortex, which is right underneath the temporal lobe, and it plays a key role in emotion regulation. And it's actually functional by I want to say 13 weeks gestation, or at least it's structurally there, and then kind of evolves over the remainder of gestation. But some work that was done by Terry Inder and some other folks identified that the insular cortex is one of those areas in the brain of premature babies that's underdeveloped. And is that, again, in any relation? Yes, we need to explore this more, but is it influenced by the lack of positive affective experiences that they've had? Oh, heavens to Betsy. And so again, just to highlight, going back to the video, the more we can grow dendrites and synapses and neural networks, we can increase the individual's potential for learning and having a really cool quality of life. But if we can't do that, we're really sentencing them to a life that it's not meeting their genetic blueprint, their full potential. Now, in the objectives, I wanted to make sure that I did tell you guys the #1 traumatic experience for an infant, it's maternal infant separation. And I thought this quote was just powerful from Antonella Gambetta Burke. Throughout history, the most brutal cultures have always been distinguished by maternal infant separation. I think it's a pretty powerful quote, and I think we have challenges as a society in America to improve maternal infant togetherness and move to that place of zero separation. If you're familiar with the work of Niels Bergman, he does a lot of talking and papers talking about this concept of zero separation to really improve the next generation. We're not so good at that. But I think in the NICU, it has an even deeper meaning because these guys are in a very precarious position. They are in a life-threatening situation. And oftentimes the mothers are critically ill as well. So how can we reduce that? Let's call it parent-infant separation. How can we get those dads in there immediately, right on admission, and have that scent there, have that positive, reassuring vocalization, which actually can release oxytocin and allow the individual to feel calmed and soothed just through positive vocalizations? So there's different creative ways that we can minimize this anxiety, this profound distress that the infant is experiencing as a result of this separation. We need to get creative, and we need to look at how we can bridge what we've created, because what we've created is not meeting the human developmental needs of these individuals. Howard et al. Did this really cool paper that looked at the results of maternal-infant separation, and through their analysis, what they identified is the occurrence of mother-child separation for a week or longer within the first 2 years of life was related to higher levels of child negativity at age 3 and aggression at age 3 and 5. And this was a healthy cohort. These weren't NICU survivors. And so just imagine if they had done an analysis on the NICU survivors. I mean, I think it would probably be difficult to do, but so again, more information to arm ourselves with taking back to the unit and saying, we've got to do this differently. We've got to do this better. Psychosocial deprivation within any caregiving environment, whether it's NICU, PICU, CVICU, truth be told, anywhere where hospitalization is, must be viewed with as much concern as any debilitating childhood disease. And I think, when I was in nurses training and when I transitioned into being a bedside nurse, particularly in the NICU, it really was all about the equipment. We had a completely blind understanding about the complexity and the vulnerability of these individuals. We looked at their vulnerability from a disease perspective, but not from a human perspective. And I think, I know I didn't serve the patients as well as I could have, being underinformed. But now there's no excuse, right? At the end of this webinar, the best thing that I can hope for is you can't unhear this, right? What I'm hoping is that this information is going to strike a chord with you. To change the environment, the first step is to change the hearts and minds. And you can change the hearts and minds with knowledge and really helping people connect with the shared humanity that we experience with our patients and their families. We are products of our childhoods, all of us, and all of us bring that to our caregiving. And what we need to understand is that the future society, and those are the people that we're taking care of in the NICU, how they move beyond the NICU experience in their understanding of what it is to be human and in relationship with other, all hinges on the relationships that we have with them, and most importantly, the relationships that hopefully we can cultivate with their families. We need to adapt and change our world in the NICU to meet their needs and meet their full potential. Why should we really care about this if I haven't already convinced you that this is wicked important? We know that toxic stress is a mediator between early childhood adversity and suboptimal outcomes in learning, behavior, and health. And so understanding the biology that underlies these well-established associations provides us with opportunities for primary prevention and early intervention, and not the after-discharge early intervention, but in the NICU, primary prevention and early intervention. And if there was one strategy I would recommend, it's kangaroo care. And I'll talk a little bit more about that. Let me see my time. All right, I'm going to show you this quick video. Not super quick, but it's important.
Everyone in a community has a vested interest in everyone else's children, because everyone else's children determine the next adult population that makes for a successful society. Built into our biology is the need to have responsive interactions with adults.
Neglect for children is when they don't get what the brain is expecting to get, what the child is expecting to get, what we are biologically prepared and waiting for, which is input from those around us.
It's this back and forth serve and return interaction that literally shapes the architecture of the brain.
Serve and return begins when a child looks at something or observes something, makes an utterance, and that represents the serve. And the return is when the parent notices the child doing these things and responds to the child.
Under conditions where serve and return is broken, you literally are pulling away what is the essential ingredient
of the development of human brain architecture.
It was a really compelling series of experiments where they started by videotaping the mother and the baby engaging in cooing and smiling. And then they asked the mother to basically put on a blank face and not respond at all. When a baby is not attended to, that is a sign of danger to the baby biologically. So the stress systems become activated.
In a brain that is constantly bathed in stress hormones, not that's up and down, that comes with normal development, certain key synapses, the connections between nerves, fail to form, and critical regions of the brain.
So neglect both fails to provide the stimulation that's needed to develop the basic architecture, and when it's at a certain level, is one of the most potent activators of the stress biology of a young child. So you get a double whammy.
Science points to 4 categories of this spectrum of neglect. The first category would be what's called occasional inattention, where children experience responsiveness most of the time, but occasionally adults don't respond. There's no harm in that, and in fact, there's probably some benefit.
A child can learn to self-soothe and explore the environment, and all of those opportunities build brain architecture.
The second category, scientists would call chronic understimulation, is where on a regular basis, children have less interaction with the adults around them than is needed for healthy development.
Those children typically, when provided with enriched learning opportunities and more typical levels of serve and return, will show catch-up.
The third category is what science would call severe neglect in a family where not only are there prolonged periods of inattention and lack of responsiveness, but often also associated with not being fed enough, not being bathed enough, not having basic needs met.
Neglect is a huge problem in the U.S. Children are much more likely to be neglected than they are to experience any other kind of maltreatment.
We see the child really being at risk for much more substantial kinds of deficits down the road that don't necessarily get easily fixed or ameliorated. This is where we really need to think about more complicated and often more intensive strategies to help undo those effects.
The fourth category, called severe neglect, generally found in institutional settings, is the result of children living in kind of warehouse-type situation in orphanages.
And it doesn't have to even be as extreme as orphanages. It can be experiences that are regretfully occurring in many, many parts of our country.
Often institutional care in this country is under the euphemistic name of transitional care or temporary care or assessment facilities.
If you think about what institutional or residential care would look like for an infant, where there's somebody new coming onto the shift every 8 hours, it really alters the development of the child's brain architecture and other aspects of the child's development.
We have the potential to change children's developmental trajectories.
Interventions can apply to parents, to foster parents or adoptive parents, childcare settings, Head Start settings, and other kinds of settings. And really, what they're about is attuning people to the serve and return process.
Neglecting young children is neglecting the foundations of a healthy next generation. The community pays a huge price later in terms of the problems of the next generation, whether it be educational achievement, economic productivity, good citizenship, the ability to parent the next generation. All of the things that have to do with a healthy, prosperous society.
And I'm not sure if you thought about this when you were watching the video, but an institutional setting could also be a hospital environment. There's lots of babies in newborn intensive care units that spend well beyond the first year of life in a hospital environment. And that is going to dramatically alter their developmental trajectory. We need to come up with a better paradigm in which to make sure, in order to make sure that we're creating the right environment, the right milieu for that child to develop as optimally as possible, because our current paradigm is just not working in a meaningful way. It's an absolute certainty that no one can know his or her own beauty unless it is reflected back to him in the mirror of another loving, caring human being. I think of that quote, you know, particularly in the work that we do as NICU clinicians, because it's really, really hard sometimes to read our babies, to read our patients. It's hard to understand what they're asking us. But I think a lot of that frustration could be mitigated by us just really trying to center ourselves with every single care encounter, really attuning to the patient and not thinking of this next care interaction as just one more do-up over a 12-hour shift, but really gathering ourselves, recalling our intention, attuning to the infant, considering what's the best, you know, action to take next, and then engaging with the infant if that's the right thing to do. That's going to really help us be able to perceive and read what is that baby telling us. Because I know a lot of you guys out there, you already do this, you know, you get a sense. We're really great when we sense that something bad is happening to this baby. I don't know what it is, but something is. We're really good at that. But sometimes, you know, we're not as good as the more, in identifying the more subtler communications, nonverbal communications that we're having with the patients. And when we aren't able to do that serve and return in the NICU, it has long-lasting negative implications for that person. What's really great about this information now is the AAP is completely on board. They're recognizing that toxic stress and early life adversity, it needs to become a never event. They're calling pediatricians and saying, all right, listen, you guys, you need to really take the helm. And I just want to throw it out there to you guys and say, what about the neonatal clinician? Because these AAP statements, they've taken all of the developmental science, you know, and they're putting together this statement, but they're still focused on the larger amount of adverse childhood adversity is in social settings and in family situations and stuff like that. But it doesn't mean that the medical trauma, the medically induced toxic stress experiences are any less important. And so it's great that we have this information. And I think we as clinicians need to bring this awareness to the medical community. We need to honor what is age appropriate for the people that we're taking care of. And, you know, people outside of our world, they may say, well, they're just babies. You know, what's the big deal? But we know what the big deal is, right? We know that the person that's born at 23 weeks gestation and is 1 day old is a different person, has different needs than the person that's born at 40 weeks gestation and is 1 day old. They're different, and we need to figure out how to honor those differences and balance the medical needs, the surgical needs with the human needs. This is an awesome conceptual model that was just put out in Advances. I think it was in August from Digata et al., bringing the research that's been done on pediatric medical trauma down into the NICU. So there's a great website that talks all about this pediatric medical trauma and stuff, and Amy and her team have really adapted that to say, look at infant medical trauma also happens. You know, pediatrics, I know it's a big umbrella for us, but I'm not a pediatric nurse, I'm a NICU nurse. My patient population is just as unique as the PICU patient population. So following birth, the infant's health status is compromised. That's why they come to the NICU. The primary care is generally transferred to the NICU caregivers, but we need to figure out how to balance that with the parents. The NICU experience differs from a routine hospital stay in a postpartum ward. Infants experience increased stress, parental separation and pain, and the NICU experience contributes to the allostatic load of the infant. And allostatic load is basically, so you're all familiar with the term homeostasis. That's when everything's all chill and everything. Allostasis is your stress response. And then theoretically, after you initiate an allostatic response, then everything goes to a new baseline of homeostasis. Allostatic load is when the stress is too much. It overwhelms the individual's abilities to cope and adapt to the stimulus. And so this leads to an increased vulnerability and risks for poorer outcomes. And so now that we've got this framework, I think this is really going to help us adopt and integrate this concept of trauma-informed age-appropriate care as the paradigm for NICU care. That first year of life is when human beings figure out it's trust versus mistrust. The world is either ridiculously scary or it is nice and loving. And bad things can happen in a nice and loving environment as long as I'm supported through a caring adult. The AAP, as a result of that, those publications and technical reports on toxic stress, they've now crafted this new model of human health and diseases, and it's about this basic, and it's going to guide the basic science of pediatrics, saying that our biology, that ecology, the environment, the social and physical environment, influences biology, either in a positive or negative way, and then that impacts the developmental trajectory of the individual in relation to health, physical and mental, across their lifespan. And so I invite you then to consider what is that intervention, and this is my last objective, right? Looking at 3 age-appropriate strategies to mitigate the stress, and I refer you to these core measures for age-appropriate care. The concept of these core measures was first introduced back in 2009. I got to work with some amazing people, Sharon Gibbons, PhD, NNP out of Sick Kids, brainiac, and Stephen Hoth, a neonatologist out of Cincinnati Children's, another super brainiac, and just wicked nice people. And we again struggled with why is developmentally supportive care practices so inconsistently adhered to and adopted. And so we used this core measure idea from the Joint Commission and said, we're going to look at these evidence-based strategies and then and organize them in a structure that you can measure if it's actually happening. You know, you're either doing it or you're not. Instead of, again, historically, I think developmental care has just been kind of like an individual, nuancey kind of a thing. And we wanted it to be really measurable and concrete. Am I doing it right or am I not doing it right kind of a thing, you know? And so we organized the results of our lit search for evidence-based practices into these 5 categories: protecting sleep, pain and stress, prevention, assessment, and management, activities of daily living, posture, feeding, and skincare, family collaborative care, and then the healing environment, which includes the physical structure, the human dimensions of that environment, and the systems. What was really cool is in 2011, the National Association of Neonatal Nurses invited me to adapt the original paper into guidelines for practice for the NAN, which was amazing. And now in 2016, an updated version of the core measures has just come out in my second book, Trauma-Informed Care, Evidence-Based Practice Guidelines, again endorsed by the National Association of Neonatal Nurses with recommendations from Carol Kenner, Heidlis Als, Sue Ludwig, Ann Stock, some really prominent people in the world of neonatology. So let me get you into some more detail around these. So if I'm going to tell you 3 recommendations for practice that will mitigate stress, I already kind of alluded to the kind of, if you can only do one thing, the one thing to do, it's kangaroo care. If you think about kangaroo care, it can only be done with the family for the most part. It is the ideal position, you know, for posture of the infant. And actually there was an interesting paper a couple years back that talked about the posture of an infant in kangaroo care actually supported development of the biceps, the muscle fibers in the biceps, which was really interesting. It is the absolute ideal healing environment for the parent and for the infant. Kangaroo care has been associated with reducing and preventing pain behavioral manifestations for different procedures. And also we know from the work of Scher and Ludington Ho that in kangaroo care, babies have a better sleep organization. They have fewer apneas and bradycardia. So that's the strategy that'll give you the biggest bang for your buck. But other strategies as well, and I alluded to the whole idea about preventing pain and really evaluating the frequency in which you do routine procedures, routine monitoring types of procedures. Really ask yourself the critical question: is this really necessary, or is this just what we do here in my NICU? And if it is what you just do, if you change your indwelling nasogastric tubes every Monday because it's just what you do, and you're not ready to make that leap of like saying, could we maybe, you know, reevaluate and spread it out or something? If at the very least what you do is you prevent the pain associated with that insertion. So for example, If the baby can tolerate it, put the baby in kangaroo, or allow the baby to breastfeed while you gently advance the feeding tube slowly based on how the infant is responding to the intervention. Now, when I was a baby NICU nurse, I was told, get in, get out, get it over with fast. So I would literally be holding the baby and just jamming that tube, thinking it was the best thing. Now the baby was, recoiling and thrashing and all this other kind of stuff. But I was taught that that's just what they do, and you want to get it over with. And it does something to you inside. You feel bad. I mean, I'm a nurse. I'm not supposed to be harming my patients. I'm supposed to be easing their suffering. And here I am doing this. And I know that a lot of my other nursing colleagues, you don't realize it in the moment, but it changes you, and not in a good way. But what's cool about this is these are nurse-driven. These are frontline clinician-driven strategies. Therapists, everybody can do these things. So again, lubricating the tip of the feeding tube, advancing it in. If they're not able to nurse, give them a pacifier. And what will happen is they'll suck. And then what do you do after they suck? They swallow. And when they swallow, you can push the tube in a little bit more and pace yourself. And what you will find, it may take you a little bit longer the first couple of times you do it, but then it'll just be the way you do it, because the response of the baby will blow you away. A colleague of mine, Myra, down in Eggleston NICU, we worked together for a couple of years, adopting these practices into their culture of care. And that was her project, was to educate everybody on this. And it has blown everybody away, how much better the infant responds to the feeding tube insertion. Let's see, what other kind of cue-based care? All right, feeding, cue-based feeding. Infant-driven feeding strategies. We now have great research now that shows that screwing 30 mLs into the head of a sleeping baby does not help them get home any quicker, and in fact may delay their discharge. And so really focusing on their capabilities and their cues to show you when they are ready for an oral feeding, and actually capitalizing on those behaviors. Not saying, well, gee whiz, I don't have enough time, I'm just going to gavage this feeding, even though the baby might be chewing their pajamas off. No, we have to be responsive to the infant every single time. And the feeding bit, that was actually analyzed by Pickler and then Tubbs and Cooley, did some really great research on this and showed that if you do cue-based feeding, the babies will actually reach full oral feedings quicker and have a shorter length of stay versus any of the other configurations of feeding. So you got to check out those papers. And it's kind of a funny slide, I know, but those cares that I suggested, it's not about doing them sometimes or occasionally, and hopefully not never. It's about everybody doing the right thing all the time. It's about meeting the human needs of these individuals, making that an always event. This is how we deliver care in our NICU. We consistently, reliably meet the age-appropriate human developmental needs of the people that we serve. Because if everybody on this call, I'm assuming you're all like totally into developmental care, and you probably rock. You probably do these things always. But if you're one out of a staff of, pick a number, 20, 50, 60, it doesn't matter that you do it right all the time if everybody else isn't doing it. So it's not only about knowing this stuff, but it's about really operationalizing it consistently and reliably. I alluded to this missed care in the NICU. They've done, lots of folks have done lots of studies. Kalish has done lots of studies about missed care in adult patient populations. And it's a big issue. In the NICU population, Rochefort and Clark, and they just did a latest paper, and I wrote a little editorial about it in my November newsletter. If you want it, you just shoot me an email, I'll send it to you. And Tubbs and Cooley, they did it on the cue-based feeding. But these are self-reports. They're anonymous self-reports by nurses. The most frequently missed care is participating in rounds. If you're not participating in rounds, then you're not present to advocate for your patient. And the unit has a big cultural issue. If you don't think you're important enough to be on rounds. Discharge planning, huge problem. And the worse the discharge planning, the more likely that infant family dyad is to get readmitted. Few days, at least within 30 days following discharge. Oral care for ventilated infants, educating and involving parents in the care, comfort care. And Rochefort et al. For the 2016 paper talk about discharge planning and comfort care. and the outcomes of these missed cares. And then oral feedings, you know, when we miss those oral feeding cues, how that compromises the patient in meaningful ways, extending their hospital stay, that's just ludicrous. So how do we make it real? And this is the home stretch, guys. I'm wrapping it up shortly. It's really about minding the gap. And I mentioned this earlier. It doesn't matter if you know all of this stuff if you don't do anything with it. The gap is between knowledge and action. And I invite you now that you can't unhear this. And you know, you don't have to take my word from it. Validate the stuff that I'm sharing with you. And then I invite you to come to the Beacon workshop in February, a pre-conference to the Graven conference. I'm doing a Beacon workshop. You can email me. I'll send you information about it. And it's going to talk all about the latest science, and there's even more cool stuff. It was really hard for me not to put it in here, but more science to really kind of, you know, engage those hearts and minds, but it's completely focused on the doing. How do you do it? How do you do it when you're no man is a prophet in his own hometown? Nobody listens to you, and you're saying everything that I'm saying here, but everybody just blows you off. We're going to get past those barriers at that workshop, so please come. And of course, I'm from Massachusetts. I'm obsessed with Dr. Seuss. And I know this is probably a guiding principle for all of you guys too. A person is a person no matter how small. And I know you all know that, and I want to thank you guys all for joining me on this workshop. If you'd like a copy of the slide deck, again, just email me, or actually I can send it out in the email with the link. Kathy, do you mind coming on with me?
Sure thing.
So I'm just flying through all of this to make sure that I haven't missed anything. So great resources, I have to say, great references. And there's my email address. Email me if you would like to have information about the Beacon workshop. The early bird registration deadline is today. But if you guys email me, I can give you the early bird rate through next week. So shoot me an email, okay? Turning it over to you, Kath.
All right, well, we'll stop the recording.